This next patient is another patient that suffers from lower extremity venous stasis ulcers. These are highly contaminated wounds. In fact, this patient didn't want to come to the hospital because he was afraid that the surgeons were going to amputate both legs. And being a gentleman who was obese and diabetic, he certainly didn't want that to happen. But once he did present to our plastic surgery service, we noticed that he suffered greatly from this high level of bacterial contamination, which turned out to be MRSA, and a high level of biofilm within the wound. He was started on closed pulse irrigation, again on a daily basis, and within a period of approximately 24 days, he started to show signs of healthy granulating tissue. And I'll show you on this bottom slide that even the epithelial cells or the skin cells are starting to grow and proliferate within the wound bed. This is a sign that the bacterial level has reached a much lower level, and it is now a healthy, ready-to-heal wound bed. And this patient opted for grafting, and this is the result after 7 days. You can see that the graft has 100% take. And so when in putting a skin graft on doing these grafting procedures, it is much more effective to perform the skin graft on a healthy wound bed rather than to perform a skin bed on a contaminated wound bed with high level of bacteria. And this is the patient 12 months after surgery. He's out and he's about and he's mowing his lawn, and he's very, very happy to have both of his legs preserved. Now, this next case is a difficult case in that these patients suffer from many times diabetes, but also venous stasis ulcer disease. And what's happening is when the blood is not flowing back from the lower extremities, they develop a lot of swelling, which can then produce these very, very painful ulcers on the leg. And this ulcer is particularly painful because it is contaminated with bacteria, and this black line surrounding the ulcer is depicting the extent of the cellulitis, which is ongoing and developing. We started closed pulse irrigation, and again, over approximately 24-day period, we can see the increase of granulation tissue and the decrease of necrotic tissue and decrease of bacteria within the wound. And it's remarkable how when the bacteria decrease, the granulation tissue is now starting to take hold and proliferate. And here we have, again, a patient who now has options. Due to the 3 weeks of CPI treatment, we were able to offer this patient a split-thickness skin graft, whereas prior to the CPI treatment, the patient really had no options except for chronic dressing changes on a daily basis, which can become very, very expensive and time-consuming. Our next patient is an 83-year-old who suffered from a traumatic contusion of her elbow. The problem for her was that she was on Coumadin. And after developing this large hematoma, it then became infected with MRSA. As I said, MRSA is now much more frequently seen in our communities. After 25 days of treatment, it is remarkable what happened to this wound. Because at the beginning of her treatment, the surgeons who were evaluating her were really suggesting that she go with an amputation of her left arm. Well, she didn't really want to do that, even at age 83, and the family was certainly set against any sort of amputation. In this slide, it's also important to point out that the patient is on Coumadin, and during her CPI treatments, she continued to receive Coumadin on a daily basis. We did monitor her INR levels on a weekly basis because we did not want to treat her with CPI if her INR was greater than 2. And she remained in a therapeutic state during all of her treatments. Sometimes we note a little bit more bloody drainage during the treatments, but it was never detrimental to the patient during her time on CPI. And again, we see that the patient was moved from a stalled position of non-healing even in a wound that's contaminated with MRSA, because I know many of you are hearing more and more about MRSA, and there's even some fear in the community that MRSA is untreatable. What I want to show you today is that CPI is a very, very effective treatment whenever you see a wound with MRSA. And this patient went on to complete healing, even though we contemplated during her treatment that she might need a skin graft. And many, many times we are pleasantly surprised after continuing CPI that we can go on to complete healing by secondary intention. And these are real success stories for the patients and for the physical therapists who treat them. This next case is, again, a very difficult case in that he has multiple pressure ulcers in the sacral region. These ulcers are connecting via a tunnel here in the lower left portion of the screen. The CPI treatments were done on a daily basis, and they were done in conjunction with a negative pressure wound device. And what's important is that, yes, you should not put a negative pressure wound device on a contaminated or dirty wound. However, if you treat the patient for 14 to 21 days with CPI, you can then apply the negative pressure dressing, reassess the patient, and again, combine these therapies because we have more options. And this patient went on to complete healing, as you can see on the lower right, due to the fact that we started CPI, created a clean, healthy wound bed before going into negative pressure wound dressings. And this was very, very beneficial for him. Again, CPI is used frequently for wound bed preparation. This is a contaminated wound on the left. It is a stage 4 sacral pressure ulcer contaminated with MRSA in a patient who's paraplegic. What we see on the right is that after approximately 2.5 weeks, we now have a wound bed which is clean and ready to heal. It was decided that the patient would require a surgical reconstruction of this stage 4 sacral wound, and this all was performed without any difficulty due to the fact that we had taken the time to prepare the wound bed with CPI. Now, what's remarkable about this particular case is that once the bacterial level within the wound was decreased to a healthy level, the patient started to feel better. Her general physiology was improving. Her appetite was improving. Her ability to think clearly was improving. And we see this time and again with CPI. Chronic wounds are a tremendous burden to the patient in a real sense from the nutritional standpoint, and we are seeing great improvement from treating the patient's wound with CPI. And as you see here, once the patient had undergone surgery, she was feeling so much better that she was started to have a better attitude and disposition on a daily basis. Our next case is very, very interesting. This is a patient who suffered from a very small ulcer on the heel of her foot. And what's happening here is she decided to go to a wound clinic on a weekly basis. And so a wound which is approximately 2 centimeters in diameter was turned into a wound with 4 to 5 centimeter diameter in the process of the wound clinic debriding on a weekly basis. And what's happening here is, despite the wound clinic making the wound bigger and cleaner, as I said earlier, they were unable to stimulate granulation tissue. So her end result was just a bigger wound. We decided to use CPI because of the selective mechanical debridement that CPI offers to our patients. Selective mechanical debridement, as I said before, will remove dead tissue without making the wound bigger. We certainly did not want to make this wound any bigger than it was, because if it did become any bigger, she was bound to lose her leg from an amputation. And so you can see here, again, approximately 25-day period, we are starting to see small islands of red, healthy granulation tissue forming. What you'll see is that these islands will start to proliferate, they'll start to get bigger and enlarge, and then they will start to coalesce and cover the entire surface of the wound bed, which gives us options for performing a skin graft. And again, we see a healthy wound ready for skin grafting, and again, 100% take of her skin graft. And this patient and her therapist developed a strong bond during her therapy, and they were very, very happy that we were able to prevent an amputation. And if you look closely at this slide, you'll see that she had previously undergone an above-knee amputation due to the same problem approximately 2 years prior to this happening. So she was extremely ecstatic that she could return to home, return to her family, and become whole again. So in summary, I would like to say that closed pulse irrigation can offer your facility improved safety for the patients and for the therapists performing the treatment, and avoid transportation costs. And we also have just seen several cases of improved outcomes due to CPI. Once again, I'd like to tell you that it is a proven technique as far as safety goes. It is a mechanical method of treating the biofilm. We can salvage contaminated hardware, which is an important step in many of our more difficult cases. We eliminate MRSA from open wounds. We do not over-debride. Many times over-debridement is performed because the surgeons are unaware that there is this new option to selective debridement. It is a bedside treatment, so it's performed in the comfort of the patient's room, and we are eliminating suction from the entire pulse irrigation technique, which results in much less pain during each treatment. We are finding this to be very cost-effective, and it will provide extremely excellent hydration for your wound bed. And many times, even patients who undergo sharp debridement can receive a CPI treatment just before the debridement, which results in a much better situation for the patient. I'd like to thank you again for having me here today, and it was a pleasure presenting to you. Thank you.